In this lecture, we are going to talk on how to perform video urodynamics in children. Children have got special needs, and the aim of the urodynamics is to reproduce the patient's symptoms. And the Nitty's principle say that the study that does not duplicate the symptoms are not diagnostic, and failure to diagnose an abnormality does not rule out an abnormality, and not all abnormalities detected are clinically significant. So the patient preparation is very important. An adequate history and physical examination should be taken. The warding history, warding diary is important. The patient should have a sterile urine culture. Laxatives have to be given the night before, and if necessary an enema has to be given on the day of procedure, because a loaded rectum does not give a proper study. You have to explain the procedure, get an informed consent. Antibiotic prophylaxis is often given, and before the procedure is started, I would always recommend a uroflow to be performed and then a PVR assessed before we start the procedure by inserting a catheter. So this is a typical warding diary which helps us to decide what kind of problems the patient faces, and once this is done, we are often able to decide whether we can avoid a invasive procedure. Typically, a urodynamics is not indicated in a patient with dysfunctional warding or simple overactive bladder, whereas a urodynamics is indicated in a patient with a neurological abnormality which lead to neurogenic bladder. So characteristics of the urodynamic curve, mostly the top curve shows a typical urodynamic curve which remains a stable pressure until the warding is there, and then at the end of the warding the bladder pressure goes up. The bottom curve shows the uroflow, which is a typical bell-shaped curve, and this curve is a normal uroflow. So that is a normal, a stable bladder. The detrusor pressure or P detrusor is a derived value. This is a P vesical minus P abdominal. P vesical is what we measure, is the vesical pressure using the vesical line, and P abdomen is a rectal pressure, and once we minus the rectal pressure or abdominal pressure from the vesical pressure, we get a detrusor pressure. So we have to get an idea of the bladder capacity, compliance, sensation, leak point pressure. All these informations have to be mentioned in the urodynamic report. The technical differences between urodynamics in a child and urodynamics in an adult or child older than 5 years is, in a child it's typically done in a lying position, whereas in an adult or an older child it is done in a sitting position. Then the second point is the leak cannot be seen very clearly in a lying position, and we have to watch for a leak in a little children. The capacity again is very slow fill. Usually how we decide the fill rate is the study has to be performed over a period of 20 minutes. So if the expected bladder capacity is 100 ml, we keep the fill rate at 5 ml per minute, so that we do the study over 20 minutes. And they are not able to void at will, these little kids, so we have to wait for the voiding to happen. Often they show some symptoms like crying or some other disturbances, and that has to be noted, and the voiding has to be assessed. Then uroflow is typically not possible, and the voiding phase is not possible in little kids. So that's the difference between urodynamics in a child and an adult or an older children. So starting in urodynamics, the first step is setting zeros, and zero pressure is the surrounding atmospheric pressure. Step 2 is calibration of the transducers, and step 3 is establishing the reference point. The reference point is superior edge of the pubic symphysis, and there should be no air bubbles in the transducers or in the lines, because once there are air bubbles, you are not able to record the pressures properly. So the quality control for a good urodynamics is initial P vesicle is around 15 to 20, initial P det is around 10 to 15, so that when you subtract it, we get a P det of around 0 to 5. So P vesicle and P abdominal are positive, and P det is also positive. So that is very important. We have to make sure that the patient coughs every 5 to 10 minutes. This is not possible again in little kids, but when they cry or when they make any noise, we can consider it as a cough, and then we have to record it as such as, and this causes an acute deflection in the curve. Then the fill rate, as I said, has to be a slow fill. Often it is a 5 ml per minute, kept over a period of 20 minutes. Faster the fill, the lower the compliance. So we have to be very careful about the fill. Now this is a urodynamic of a patient who had a neurogenic bladder, and we have to make sure that we have calibrated the transducers properly. So a calibration of the transducers involves adjusting the rectal pressure, and this is the transducer being adjusted, and once the transducers are got rid of the air bubbles, we have to insert the rectal line and the vesical line and adjust the rectal bulb pressure. So the rectal bulb pressure is often adjusted by deflating a little bit of the rectal balloon, and then we make it in such a way that the P abdomen is around 15 to 20, so that P vesicle, if it is 20 again, you get a P det of 0. So before starting the procedure, we have to make sure that the P det is between 0 to 5. It's in the positive range. So that is important. And once we get all these things ready, we have to make sure that there is no sudden increase or decrease in P vesicle or abdominal. Whenever there is a smooth increase in P vesicle, we can understand that it can be because of an impaired compliance itself, or it can be because of a rapid fill. When there is a smooth increase in abdominal pressure, we know that it can be because of a rectal contraction. So these are some of the things, and here you can see the first deflection shows only a movement in the second line, which is a rectal line. So that's a rectal contraction causing a negative deflection in the P det. The second arrow marks a cough, which is an acute wave. So that is there reflected in the first curve, which is a P vesicle, and second curve P abdominal, but that is subtracted nicely, and that is not seen in the P detrusor. And there is a third deflection. Actually, there are two deflections seen on the vesicle line. They are the true contractions, vesical contractions. They are not an acute curve, but they are a smooth curve. They are not reflected in the P abdomen, which is a rectal line. So they are the two true detrusor contractions, which is also reflected in the P det. So we should be able to understand and differentiate these two curve points. So the change in bladder volume per unit change in pressure is the compliance, which is delta V by delta P. Normal compliance is around 30 ml per centimeter, and non-compliance or impaired compliance means the pressure rises very rapidly, so the curve becomes too high in the slope. The slope of the curve is very steep. So the non-compliance is severe compliance, which is less than 10, moderate compliance is 19 to 10, and then mild impairment is 29 to 30. So this is a typical example of an unstable contraction where the contractions are seen on the P vesicle line, which is the first line, and then on the last line, P detrusor line. So these are smooth waves which are seen. This is a typical example of a non-compliance or with the instability. So there are unstable contractions, and there is a steep rise in this curve slope. So this is a typical example of increasing slope, which is a sign of a poor compliance. So an ideal UDS report should mention about the storage phase, whether there was any leak during the storage, whether there was any unstable contractions during the storage, and if there is a video urodynamics, we can also mention whether there is a reflux. A warding phase again should tell whether the warding is of a good pressure, whether the warding is to the completion, and whether there are any interrupted voidings due to sphincter problems. Uroflow is often done at the end of the procedure, and the typical uroflow is a bell-shaped curve, and uroflow PVR, that's post-void residual, has to be less than 10%. So uroflow can be multiple different types based on the sphincter disorders. Detrusor sphincter dyssynergy often causes a staccato voiding, whereas a fixed outlet obstruction causes a flat uroflow. So that's about how to perform urodynamics and uroflow. Thank you.